organ, mesoperitoneal, and, for example, colon ascendens, descendens. Yes, they are not covered from the back, but sometimes when they becomes full with undigested masses, they becomes maybe intra-meso, transitional position, but usually mesoperitoneal they have. And some organs are located behind peritoneal cavity, kidney, ureter, pancreas, duodenum. Yeah? They are extraperitoneal organ. What three position we can distinguish? Intra, meso, and extra. And you must give during oral test. Please name intraperitoneal organs of abdominal cavity. You must name. For example, liver, stomach, spleen, colon transversum, cecum, appendix, sigmoidium, upper part of the rectum, initial, the first part of the duodenum. Mesoperitoneal organs. Gallbladder when it is filled, urinary bladder when it is filled, when it is empty, it is extraperitoneal. Colon ascendens, colon descendens, the middle part of the rectum, mesoperitoneal. Extraperitoneal organs, pancreas, duodenum, lower part of the rectum, kidney, ureter, they are not digestive organ, but also extraperitoneal position they have. At female, this peritoneal cavity has communication with external environment through the uterine tube. Infection, for example, through vagina, through the uterus. Uterus on both sides has uterine tube, and this uterine tube, they have ostium uterinum and ostium abdominale. Each tube, how many opening have? Has two opening. One opening is uterine, next opening ostium abdominale. Where it is open? In abdominal cavity. And infection can pass with abdominal into the peritoneal cavity. Yes, from peritoneal cavity and between peritoneal cavity and external environment through the vagina. The peritoneal female cavity has communication. That is why it is not closed sac as a male body. Understand this? And between these two layers, we have not histological differences. Sounds like the peritoneum parietale, it has more lymphatic vessels, and function of peritoneum parietale is absorption of the fluid which is produced by this mesothelium produced secretion. A small quantity, 20-40 milliliter of the secretion is produced in peritoneal cavity, which reduces friction between organs, yes, and helps peristaltics, peristals of the organ. And visceral peritoneum mainly produce this fluid, and we have balance between production and absorption. When this balance is destroyed, in the peritoneal cavity is accumulated fluid. This condition is called ascites, ascites in Latin, ascites, да, или ascit. Ascites, по-моему, ascites, не ascitus. Ascit, it is accumulation condition when the fluid is accumulated in peritoneal cavity. Ascites, it is in English called ascites. Now we'll describe the course of peritoneum in sagittal direction and frontal direction. We will start from anterior abdominal wall above the umbilical ring, parietal peritoneum, blue color, it has marked here, blue color parietal peritoneum goes from anterior abdominal wall to the diaphragm, and it is reflected on the liver. What ligament it forms? On sagittal section we can see this ligament. What ligament in frontal section it forms? What? When it goes, no, it goes from diaphragm to liver. What? What? Falciforme in frontal direction. It goes from diaphragm to the liver. Ligamentum coronarium hepatis. This from median section, through midline. What ligament we can see here? Do you understand? and from the back peritoneum covers the diaphragm and reflects it to the posterior inferior surface of the liver. Thus, when we'll see, this is sagittal section, this frontal direction. In frontal direction, this ligament which goes from the diaphragm to the liver and keeps diaphragm, hangs liver on diaphragm. What name has? Coronarium. And on both sides, two layers. And from right and left side, these two layers, two halves, join together and in sagittal direction form falciforme hepatis. They are all peritoneal folds which goes from the diaphragm to the liver. It consists of two layers, ligamentum coronarium in frontal, in sagittal falciforme, and on both sides triangulare, and in anterior part of this the ligamentum teres. And remember that between these anterior and posterior parts of the liver, from front and back, we have small area, area nuda, bare area, which is not covered by serous coat. It is covered by fibrous tissue and fixated liver to diaphragm. It is one of the fixated components of the liver to the diaphragm. Yeah? What region is this between two layers? This region is what? Area nuda, this region. On section between anterior, when from front goes and from back, between these two layers, what layer we have? Area nuda, area nuda. Then in the hepatic porta, how many layers meet from front to inferior visceral surface, from back to inferior surface? Two layers of peritoneum, parietal, continues to the visceral, red color, visceral. And then from hepatic porta, two layers of peritoneum goes to the stomach and there from each other and cover the anterior surface, posterior surface of the stomach. Yeah? From hepatic porta, in which are located ductus hepaticus communis, vena porta, arteria hepatica, and these two layers of the peritoneum goes in front and behind stomach and meet near the greater curvature. And here you can see ligamentum, what ligament? Hepatogastricum. In Russian, part of omentum minus, chest, part of omentum minus. Why we can see only hepatogastricum? Because on midline section we can see only this what section? Midline section. And view from the lateral side. Do you understand this and this? This frontal, if you cut and see from the lateral side, from inside, you can see only what ligament on midline section? Hepatogastricum. But also we have in frontal direction hepatoduodenale, hepatogastricum. Two ligaments from liver go to the duodenum. That is why initial part of the liver, what covering has? Intraperitoneal, like stomach, intraperitoneal. You understand? Two layers go to the lesser curvature, diverge, cover stomach, and once more mix, join together in greater curvature. The stomach, what position has? Intraperitoneal. See this picture of the stomach? You can see stomach has this serous covering. Tunica serosa. This gray color is tunica serosa, only diverge near the lesser greater curvature where the vessels and nerves are located. These two layers diverge and we have so-called coronary vessels of the stomach along the lesser and greater curvature. Thus, on the greater curvature, we have two layers of peritoneum mixed together, joined together, and they descend below until don't reach the pubic symphysis. Above pubic symphysis, turn to the back. These two layers of the peritoneal fold turn to the back. Then to the back. Then these two layers, it is better visible, this part is not good, in your textbook. You can see from here, posterior layer, during development, it is a result of, in adult, we have fusion. During development of the peritoneum, these two posterior layers continue on posterior abdominal wall. Thus, we have how many folds? Layers. 4 layers of peritoneal folds from greater omentum or epipleon. Greek name is epipleon. This epipleon It consists of how many definition you will give? Fold of the peritoneum, which consists of 4 layers, which form 2 lamina. Anterior consists of 2 layers, and posterior 2 layers. Anterior lamina starts from greater curvature of stomach. Posterior lamina is attached to tenio mentalis of colon transversum. This fold of peritoneum of 4 layers has name great omentum, omentum majus. It is depot of the fat in our body, reserve of the fat. If the man is very thin, his omentum is more thick and more thin, vice versa. Then, this fold, but during, continue. This posterior wall, 2 layers. During development, continue on the posterior abdominal wall. In adult, after birth, after first years of the birth, children, they anterior and posterior lamina fuse together, close, fuse together, and attached to the tenio mentalis of colon transversum. Thus, here they are separately drawn, explained the course part of the peritoneum. The posterior 2 layers, how go? Go to the posterior abdominal wall, continues with parietal peritoneum, which covers pancreas, retroperitoneally located, and then turn and form superior layer of mesocolon transversum, covers mesocolon transversum, and form inferior layer of the mesocolon transversum, and once more continues as parietal layer. This posterior lamina of great omentum is fused with mesocolon transversum. Here you can see the posterior lamina which goes to posterior wall. It is fused with mesocolon transversum. But during development it goes, this 2 layer goes. Here is shown the mechanism of formation of mesocolon transversum. It is a result of fusion. This mesocolon transversum, when these 2 posterior layers go and continues up and down, turn, covers. You understand? This 2 layer goes, and here lies pancreas. One goes to there. Pancreas is triangular there on section. It has superior, inferior, and posterior. 1 layer from this 2 goes posterior there. Posterior 2 layers go to the pancreas. When our inferior surface is retained and form the superior layer of mesocolon transversum, then covers colon transversum and form the inferior layer of colon transversum and goes. Thus, this posterior lamina is fused with mesocolon transversum, and they together form the inferior wall of this sac, which is called what? Omental bursa, the inferior wall of omental bursa form. Omental bursa is small cavity of peritoneum which lies behind the stomach. Thus, we understand how is the less omentum and great omentum. Remind me, less omentum of what 2 ligaments form? Less omentum. What 2 ligaments form? Hepatoduodenale, What 3 structures are located in hepatoduodenal ligament? Ductus choledochus, vena porta, arteria hepatica propria, DVA, are located inside this during operation on the gallbladder. This ligament is very important. Surgeon open this ligament, hepatoduodenal, and open choledochus and give ligature on ductus cysticus, separate from choledochus. After only this, take away cholecystectomy. That is why this ligament is very important. And what 3 structures we have inside, once more? What abbreviation they have? DVA. Ductus vena arteria. Must be green. Here is blue. I don't understand. Green, vena, venous blood, and arteria. DVA, from right to left. Remember, it is for all years, on the surgery department especially. ABC of abdominal cavity, it is very important. Then, an anatomical abbreviation, it is famous abbreviation. Do you understand два? Russian два. Два. Да. What is this? Great omen. And now in frontal direction. From anterior wall, peritoneum goes to the lateral wall. Anterior wall goes, here we describe on sagittal section. For understanding of formation of mesentery, we'll describe in frontal direction. From anterior wall it goes to the lateral wall, cover the lateral sides of colon ascendens, colon descendens, in front and lateral sides. Mesoperitoneally covered. And then from the right and left parietal peritoneum, two layers joined together, and between these two layers are located mesenteric vessels, and these two layers go to what? Small intestine, jejunum and ileum. Only jejunum and ileum together have intraperitoneal covering. These two layers from posterior wall with the vessels come and cover tunica serosa. Cover jejunum and ileum. That is why jejunum and ileum, they have intraperitoneal position. And what is this? If you will cut, you can see the root where this mesentery starts, originates. From the root, the tree grows and it has root. This is origin of mesentery, the radix, root of the mesentery. How it is formed? From the right and left sinuses mesenteric, two layers of peritoneum join together and then go and cover intestine. And this is a root which goes obliquely from the level of the second lumbar vertebra to the right iliac fossa, about 70-21 centimeters, to the level of iliocecal angle, angulus iliocecalis. This is called, and also it is level of right sacroiliac articulatio sacroiliaca junction. Articulation, and also level of right iliac fossa. What we want, you can name. In the region of right iliac fossa ended, or sacroiliac junction ended, or in iliocecal angle ended. This root radix mesentery, which crosses what structures? Aorta, vena cava inferior, right ureter, and ended here. And when the ileum here is open, above and below, you can see two pockets, recesses, iliocecal. Recess iliocecalis superior, inferior. Behind, the cecum is covered from all sides intraperitoneally, but it has not mesocecum. Only appendix has mesoappendix. Intraperitoneal with mesoappendix. Intraperitoneal without mesocecum. But in pathological condition, maybe have mesocecum. In this, you will listen lecture, special lecture, cecum mobile. It is very difficult surgical pathology during which cecum can move in all peritoneal cavity and different position. When it has, as a result of abnormal development, has mesocecum. But in the normal condition, it has not mesocecum. It covered, but lies in this fossa, and behind cecum, what recesses we have? Retrocecal recesses. Recessus retrocecalis. Recessus iliocecalis superior inferior, recessus retrocecalis. Thus, on posterior abdominal wall, here we have two sinuses, the right, the left, mesenteric sinus. The root of the mesentery, the posterior abdominal wall, divides into two peritoneal sinuses. Mesenteric sinus, sinus mesentericus dexter, the base of this triangle faced upward. This triangle, yes? Colon ascendens, colon mesocolon transversum, and radix mesenteria. And this is sinus mesentericus sinister. Below is formed by mesocolon sigmoideum, which has right and left layers from mesocolon sigmoideum. And on left layer, if you will turn on this side on preparation, you can see recessus intersigmoideus, into this recess. These recesses are formed as a result of development, but what clinical significance they have? Into this recess can pass loop of intestine during peristaltic and form retroperitoneal herniation, which disturb peristaltic. If some loops pass inside this pocket and they don't participate in peristaltical movements, it is abnormal. Retroperitoneal herniation, so called pathological condition may be developed. That is why you must know that we have, when the duodenum continues with jejunum, duodenal recess, superior and inferior duodenal recess, ileocecal recess, retrocecal, and intersigmoid recess of the posterior abdominal wall. On both sides of colon ascendens descendens, we have paracolic grooves, gutters, sulcus paracolicus. Dexter, sulcus paracolicus. Ну, в 11, да. Да.
Ну, мы в 11. А на лекционных где?
Пошла препараты показывать. Sulcus paracolicus dexter, sulcus paracolicus sinister. Yeah? And from upper story, inflammation can pass into the pelvic cavity. What sinus? Inflammation of what? Right or left sinus more dangerous?
Right.
Why right? Right is closed sinus, and inflammation may be accumulated only in this sinus and keep in this sinus, but left has communication with pelvic cavity. More dangerous is this. From left can pass pelvioperitonitis maybe. It has communication with the pelvic. This is closed sinus. Left sinus is more inflammation, more dangerous. And from upper story, this sinus is the sac, bursa, sac. Bursa also we have in the joints, yes, but here we have peritoneal bursa. In upper story we have free bursa. I will describe now. And from this bursa help to keep inflammation inside this region. For example, in stomach, after ulceration of the wall, like wound of the skin, the same wound may be in the wall of the tunica, mucosa, muscular, and this wound can be perforated and contents of the stomach can pass behind stomach into this sac. It is called perforative ulcer of the stomach. Very dangerous condition, but inflammation may be delimited by this sac. At first time, the local peritonitis is developed. The sac helps for localization of inflammation. At first, maybe localized in this region, but this sac has communication with peritoneal cavity. If this patient don't give in operation emergency aid, inflammation can pass and spread in all peritoneal cavity through this foramen. In this case is developed what inflammation? The general diffuse peritonitis. At first local, and then diffuse peritonitis. That's what significance have this sac. They delimited this inflammation in local space, but through the upper story, through these paracolic gutters, especially right, inflammation can pass into the pelvic cavity and develop peritonitis. Yeah? For example, sometimes in appendix, when perform appendectomy, very sometimes surgeon very difficult case, very difficult inflammation because it is complicated by peritonitis. Also develop the general reaction of the peritoneum is inflammation. It is protective reaction. You must understand that peritoneum has protective reaction. It is participate in inflammation of any organ. It gives reaction. It is inflamed and gives pain, high temperature, and symptom. You will check symptom in clinic. Symptom Shotkin-Bloomberger. This symptom you will give peritonitis. They very acute pain they feel because it is reaction of the peritoneum. In appendicitis, in this right iliac fossa region, point of McBurney, point of length, if you remember this point, projection of the appendix. Do you remember? Just last classes you study large intestine, point of McBurney and length. No? This projection of appendix. Come. Stay here. I will demonstrate. Иди сюда.
You, Asha, go.
Umbilical region and anterior superior iliac spine. If you will join and divide in three parts between external foot and middle foot, about here. You will check them. Yeah? McBurney point. And if this 1 point. And if you will join two anterior superior iliac spine, Can you touch this?
Yes.
You don't draw on the patient, but in your mind you will draw this line, divide in 3 parts, and between external and middle foot also is projection of point of lance. Thank you, my assistant. Continue. Let's, in conditional, we can divide abdominal cavity into upper story, middle story, and lower story. And in each part we can describe. In upper story, we can describe 3 sex. In middle story, we can describe these paracolic gutters, root of the mesentery, 2 sinuses. And in lower story, we can describe relation of the pelvic cavity organs to peritoneum, recesses. At male and female body, different recesses are formed. In upper story, what 3 sacs are formed? Bursa hepatica, bursa pregastrica, bursa omentalis. 3 bursa are formed. One bursa is this. Now imagine anterior abdominal wall. It is better demonstrate on preparation. Between diaphragm, falciform ligament, colon, mesocolon transversum, and abdominal wall. This part is called, this ligament goes until umbilical region. It has what space? In this hepatic bursa is located the right lobe of the liver, and we have what cleft-like space? Subphrenic and subhepatic. Between diaphragm wall, anterolateral wall, colon, mesocolon transversum, and falciform ligament which separate. Do you understand what bursa we have? Inflammation, for example, abscess of the right lobe, can be accumulated, located in this region at first, hepatic bursa. What part of hepatic bursa can distinguish? Subphrenic cleft and subhepatic cleft. To the left of falciform ligament, which separates from hepatic bursa, we can distinguish pregastric, the left lobe of the liver, anterior surface of the stomach and less omentum, and also spleen. They are located in what bursa? Pregastric. Pregastric. Behind stomach we have retrogastric, but it has another name, omental bursa. Omental bursa. Stomach, from 2 points here, it has been removed here from cardiac and pyloric orifice. And behind you can see some space of the peritoneum, which is called omental bursa. On this section here, this space behind stomach, what name has? Omental bursa. On this section, here you can understand how from anterior wall, peritoneum goes to lateral sides, here from the paracolic, this sulcum, and then from the right and left layers of mesentery, mechanism of formation of mesentery and paracolic. Each pictures you must understand. Here, posterior wall of omental bursa, and posterior wall of abdominal cavity, root of the mesentery. On this picture, you can see it's much lower, more lower, what this level, through the loops of small intestine. This through the liver, upper story, middle story, horizontal. There, cats we have here. Liver, stomach, spleen, and posterior retroperitoneal organs. This, here we have hepatic bursa. This space is called hepatic. Until this pregastric cleft-like space between anterior wall, spleen lies inside, anterior surface of the stomach, less omentum, left lobe, and falciform. This space, what name have? Pregastric. And this cleft-like space is called omental bursa. Or by localization, it is retrogastric or omental bursa. This omental bursa lies behind stomach, less omentum, and some part of great omentum is called great omentum part, which lies between stomach and colon transversum. It has what name? This part. This part. Gastrocolic ligament. This, what's happened? Anterior wall, by this picture standing, anterior wall of the omental bursa, 3 structures. Less omentum, posterior wall of the stomach, and gastrocolic ligament form the anterior wall of this bursa.